you, however, that remember there was a week of sub-zero temperature last year, which killed several of my plants, and recognize that this is only going to get worse. Say, this is something you're going to see. We saw a little tiny bit of it last year. We actually saw a little bit years before, but you're going to see more of this. And since I'm originally from Buffalo and have seen a fair amount of this, I thought I'd be a good one to talk about it. So, cold weather injuries. You're going to see them whether you want to or not. Well, at the start, we're going to divide this up into two separate categories. Cold weather injuries can be either systematic or local injuries, or obviously they can be both. And we'll talk about each of these separately and what you do about each of these. Body temperature, core temperature is what we're talking about. And when the core temperature goes down, cellular metabolism goes down. Sometimes this is a good thing. This is what we are looking for when we make people hypothermic in the SICU to try to decrease the metabolism in the brain, keep the brain alive longer, require less in the way of oxygen, less in the way of nutrients. Well, you can take the temperature down so far, and then something happens. You start to get ice crystals formed in the cells, they rupture the cell membranes, and at that point, death occurs. Now, why this occurs in mammals is unclear. I remember distinctly years ago when I used to be, sometimes went out and hunted in the south of New York, and we had a cabin there, or we didn't, a friend of mine did, and we went in there one fall. It was sub-zero temperatures, and the floor was littered with flies. I mean, basically dead flies. And we swept them out, turned the heat on in the house, you know, and 2 hours later, the flies that we hadn't swept out were flying around. So obviously, cells can survive very cold temperatures. What makes that different than us, I honestly don't know. But anyway, the point is that you can get colder and colder and colder until you form these ice crystals. Then you have cell death, and then there's not much you can do about it. Well, so how do we manage this? Core temperature is basically a balance between the heat you make as a mammal and the heat you lose to your environment. Heat production is metabolic in nature, obviously. So the more heat you make, the more active your metabolism is, the more energy you're going to require. Heat loss, on the other hand, is a physical thing. We can either lose this just by radiating heat, you can radiate heat. Evaporative loss is, of course, what we use to cool ourselves in the summer with sweat. Conduction, heat can just go from your body into whatever you're lying on, or directly into your environment. And convection is where you have change in your environment so that heat goes into the environment, it rises, and another more cool air, or cool whatever, comes and surrounds you. So those are basically the four mechanisms of heat loss. And, you know, other than the fact that this is how you lose heat, they're not really important for what we're going to talk about. So, you start to get cold. What do? Well, we all know this stuff. I'll just go over it very briefly. First thing that happens is circulation gets shifted from the skin to the core. We all know this. Your metabolism increases, and you manifest this with shivering, which is actually your most important mechanism for maintaining heat. It's the increased metabolism and increased muscular activity you get with shivering. And this will be very important in a little bit. Now, how does this all work? Well, there are small anastomosis, arterial anastomosis in the skin. They're controlled by both the hypothalamus, and that's both alpha and beta, and local nitric oxide. So I don't know what, I've always wondered with this where some of the things like Viagra would fit in here. But anyway, nitric oxide also controls flow through these channels, which basically takes blood away from the skin or toward the skin, depending on what you want. Normally, your flow is about 200 to 500 milliliters per minute. At 14 degrees centigrade, this can decrease to 20 to 50 milliliters a minute. And at 37 degrees centigrade, obviously normal temperature or above, it can increase to 700 to 800 milliliters per minute. as your body tries to get rid of excess heat. At 15 degrees, you hit maximum. That's as constricted, that is as much blood as you can get into your core is at 15 degrees. And at 10 degrees, something called a hunting reflex occurs, which means the body now doesn't know what to do. So the channels open, they close, they open, they close. They're sort of, it's loss of control, but obviously this will lead to further heat loss. Okay. So, I said there were systemic and local injuries with cold. First is, we're talking about the systemic injuries. That's hypothermia. And this is probably what you're most likely going to start seeing down here. It's defined as a core temperature less than 35 degrees centigrade. What happens there? Well, I've talked about some of the defenses and what the body does when it gets cold. But this is what it really boils down to. First of all, you have a cardiovascular response. You have a tachycardia, vasoconstriction, trying to keep the heat in the core, increased myocardial consumption as it tries to keep the heat in the core, and also has to pump against increased peripheral resistance. Eventually, this is followed by bradycardia, decreased contractility, decreased mean arterial pressure, and the cardiac output starts to drop. Once the cardiac output starts to drop, you know you're starting to have problems because you're starting to lose your defense mechanisms. This is manifested on the EKG by an Osborne wave. This is just the second peaked wave. It's due to repolarization occurring inappropriately, but it's supposedly pathognomonic for hypothermia. Other physiologic effects. Respiratory rate. Well, you start to breathe slower. You hypoventilate, start to retain CO2, and you start to become acidotic. In the central nervous system, what happens? Well, at 34 degrees, that's 3 degrees down from normal, you start to see EEG changes. I mean, that's not much. I know I've been that low. And if any of you have ever done outdoors things, particularly in the north, there's a chance that you've had a core temperature that low. So you start to see EEG changes at 34 degrees. You start seeing decreased activity. Now we're down a lot colder, down at 28 degrees, and this is core temperature again. And finally, auto-regulation fails at 26 degrees. And this becomes very important because at this point, you can no longer passively rewarm somebody. Other things that happen, platelet function decreases, platelet count decreases because you start to sequester platelets in the portal system, but also you start to sequester them peripherally, which can, in the long term, lead to decreased blood flow. And you have something called cold diaries. Does anybody know what this is? Anybody here a scuba diver? God, am I the only one? Okay, well, I can tell you something happens when you go scuba diving. At about 15 minutes into the dive, you have to pee. Why do you think that is?
Aquaporins. Aquaporins.
Aquaporins, yeah. No, basically what happens is you're diving, generally you're not diving in body temperature water. You're diving in water, even at only at 80 degrees, your body starts to cool. The normal response is to pull blood into the core. Well, the blood in the core, the kidneys now see an increased flow and they go, oh, we got too much blood, we got to make urine. So they fill the bladder. So this should tell you two things. I mean, it's a nice little story. It's probably a good idea not to wear somebody else's wetsuit, but what it does is it means that anybody that's hypothermic is also going to be hypovolemic because they will feed off their normal interstitial fluid and intravascular fluids. Okay. Anyway, further classification. Hypothermia, mild hypothermia is 32 to 35 degrees. That's for those of you that insist on not joining the rest of the world, that's 90 to 95 degrees Fahrenheit. Moderate hypothermia, 28 to 32 degrees, and severe is less than 28. And we'll talk about each of these. First of all, mild hypothermia. Well, first of all, here, your your normal mechanisms are still in play. Your body basically is still working, it's just getting colder. And your metabolism is going down. You're going to start shivering because, like I said, that's your body's defense against hypothermia. That's the best way that it can raise temperature. Vasoconstriction, tachycardia, all these things we've talked about are going to occur. And you're going to have progressive neurologic effects. And even you can start seeing ataxia and dysarthria at this point, even though that's not that cold. Well, actually, it is kind of cold at 90 degrees Fahrenheit. That is kind of cold. But when you look at the big picture, the central nervous system starts to be affected very early. And I can almost attest for this. I can remember coming back from military base one time on a motorcycle when I got caught in a cold snap and having to stop less than a mile from where I was going to go because I was so dysarthric, I was basically unable to move and had to walk off the bike, go to basically a Waffle House, how low can you sink, and just get in there and warm up before I could actually walk again. And I'm betting my core temperature was probably somewhere around 33, 34 at that time. So it does affect you, and of course, if you're in an inclement situation, this makes it harder for you to get out of the inclement state. So these things become cyclic, they become worse. Now, moderate hypothermia, now you're talking about the start of trouble. Bradycardia begins right at the start, 32 degrees. Become poikilothermic. What does this mean? It means you can no longer rebuild your core temperature. At this point in time, just covering somebody up and keeping them warm isn't going to be adequate because they no longer have that shivering response. They no longer have that ability to generate their own heat. Arrhythmias start at about 29 degrees. Apnea occurs at 23 degrees, which is actually severe hypothermia. But I just put it in here because this is how this thing trends. And the shutdown has begun at about 28 degrees. Less than 28 degrees, severe hypothermia, and people have survived this. You're going to be in a coma. You're not going to have any compensatory functions at all. You're going to be acidotic. Remember, we had CO2 retention. You're going to see cardiac fibrillation. And at this point in time, you can't defibrillate them. You have to warm them up before you can get the heart back into a normal rhythm. Any of the normal ACLS things you do for fibrillation won't work when you're at this point in time. As we noted, you become apneic at 23 degrees, and asystole occurs at 20 degrees. Now, the interesting thing is, even at 20 degrees here, you're not necessarily dead until those ice crystals start to form. But you're pretty damn close. Okay, concepts of rest, and I've sort of alluded to this. At 30 degrees, you're poikilothermic. You're going to need some type of aggressive warming. We can no longer just cover them up and say you're going to keep them warm and rely on their own body heat and their own metabolism to bring them back to normal. And like I said, once you hit the arrhythmias at about 28 degrees, nothing you're going to do if the patient is below this is going to help until you get them up, usually to about 30 degrees, and then you may have some success. Once extensive cell death, and you see this number quoted fairly frequently, if the potassium is greater than 10 when you get the patient, if it's greater than 10, and they don't have another reason for high potassium like renal failure or rhabdomyolysis or some type of endocrine problem, you might as well give up. You're never going to resuscitate these patients. Potassium over 10 or pH below 7. If there's any doubt, however, the basic concept is warm them up to about 35 degrees. All right, well, these are all the ways we can rewarm people. Let's talk about each of them. First of all, but first I need to mention this. There's one other little thing that occurs, and that is when you start to passively warm somebody, you get an afterdrop. They actually get colder because blood starts to flow to the periphery, which is actually colder than the core, and that cold blood gets brought back to the core. So you can actually make somebody worse before you make them better, particularly with passive rewarming, and even with active rewarming, as we'll see in a second. So, mild hypothermia, you can start passive rewarming, down to about 30 degrees centigrade. And this is the things you can do with passive rewarming. You can put them in a warm environment. I mean, this makes sense. they're shivering, you allow shivering, you cover them with blankets, cover the head, do everything you can to decrease further heat loss and let the body recover. It will take care of itself as long as you decrease the ongoing heat loss. Now moderate, that's 28 to 32 degrees. Now you've got other things going on. You can either actively rewarm them externally or actively rewarm them internally. External rewarming, heating pads, warm blankets and stuff. I mean, this all makes sense. But again, remember that you have that potential. Once you start warming the skin, the capillaries will open up, flow will increase to the skin, and you're going to be bringing that cold blood back to the core. You will actually have a potential drop. So these things are not as, they're readily available, but you have to remember that you have the potential of causing problems. Immersion, putting somebody in warm water, this is probably a better way to do it because it will transfer heat much more rapidly. External lamps, when I was in the burn unit, we used to use these things. They look like the things that keep your French fries warm at McDonald's. But they're fairly useful in somebody that is not really severely hypothermic. Internal warming, the first thing everybody thinks of is heated IV fluids, and this sounds fine. The reality is that unless you're pouring liters and liters of fluids into somebody, warm fluids is not going to make that much of a difference. You can't really warm somebody that way. Although obviously you're not going to give them cold fluids. Gastric and colonic lavage, a little more successful, an NG tube, rectal tubes, warm fluids, fluid at probably about 40 degrees. A little more effective. Peritoneal lavage is what it says. Lavage catheter in the belly, warm fluids. Wonderful. Mediastinal lavage. Now, I've never done this. Sounds impressive. Might be a little exciting. And warmed inhalation agents. Again, you're going to have these people on the vent. You're going to use warmed air, moist air to keep them warm. This is useful also, but again, just like the IV fluids, it's not as useful as you would like. It doesn't raise the temperature that much. And finally, when you get up to severe, these are the things that work. Warm dialysis, CRT, or the thing that's most useful, the thing that I've been most impressed with, if you can get it done, is putting them on cardiopulmonary bypass. And this will bring people back amazingly well. When I was up in Wisconsin, I have to remember they dragged this lady in that had been lying out in the snow, forgot how long, and I forget what her core temperature was, and she was fibrillating. And the residents who'd been up there, I'd just come back from a, shall we say, more temperate climate. The resident says, well, we'll get the CT folks to put her on bypass. And I'm going, oh, sure they will. Well, they did, and she survived. She was a little strange after that, but reportedly she was strange. So anyway, the final thing, if you can get them on cardiopulmonary bypass for moderate or particularly severe hypothermia, this is probably the best approach. Okay, so if you happen to be at the scene of one of these, what are you going to do? Well, if the patient is shivering, you want them to shiver because this is what's increasing their core temperature. Dry them off so that they're not losing heat through conduction or evaporation. Insulate them, keep them, do everything you can to keep them warm, to allow them to maintain their core temperature, maintain their own generated heat. These people, of course, you can, if they're awake and alert, and usually they are at this point in time, give them something hot to drink, something hot to eat. But remember, once again, local heating may actually cause problems, not only because, as I said, you have blood flow, cool blood flow from the periphery, but you may actually decrease the shivering response. You want that shivering response. Decreasing the shivering response will actually delay their recovery. If they're not shivering, do whatever you can. Okay. So, finally, once they make it to the treatment center, what are you going to do? Well, remember right at the start I said these people are hypovolemic. So you need to replace the hypovolemia, and you need to do it with warm fluids. They can have extravascular loss too. You do have to worry about overload. So, you know, it's the usual balance between resuscitating them to normal volume and not overloading them. To correct the acidosis, and you can correct the acidosis in several mechanisms, but these are people that may benefit from bicarbonate. And just rewarm them in whatever one of those mechanisms we talked about. Okay, and that basically is it for hypothermia, which is, like I say, the thing we're most likely to see in this situation here, where most of the time when it gets below freezing, it doesn't get all that much below freezing. Now these are the 4 basic local cold injuries: frostnip, chilblains, frostbite, and trench foot. Frostnip is just something that happens. Skin gets cold, you get a little decreased blood flow, it becomes white, you get local vasoconstriction, but there's no long-term damage. Sometimes these people become more sensitive to cold when they're re-exposed to it, but by and large there's no damage associated with this injury. Chilblains, on the other hand, are actually a long-term issue. This is re-exposure to an area that was previously injured, and that injury could be either mild frostbite or significant frostnip. But this is a neurologic issue. It has an inflammatory basis. This can go on quite some time. Basically, the skin turns red, it may blister. Again, it's not life or limb threatening, but it's very painful and can be debilitating to a patient for an extended period of time, because just warming them up doesn't necessarily make their symptoms go away. The British military has tried calcium channel blockers, particularly nifedipine. Reviews are mixed. Basically, the way you cure this is you don't let it get cold again. Frostbite is what everybody thinks about. This is where you have actual tissue loss, actual injury to the tissue, basically because of freezing and because of cell membrane rupture. It's like everything else, divided into categories or degrees. First degree, numbness, erythema, raised plaque, possible slight epidermal sloughing. Second degree, vesiculation with clear fluid, and this has become important in a minute. Third degree is deep hemorrhagic blisters. Injury is below the dermis. The other injury is above the dermis. This is below the dermis. And fourth degree pretty much involves everything. This is kind of silly. I mean, it's one of those nitpicking things. So most people just classify it like this: superficial frostbite, and that's first and second degree, minimal or no tissue loss, and deep injury, third and fourth, what would be third and fourth degree. You're going to anticipate the tissue loss. One of the things to remember here, these people are going to have clear blisters. When they have blisters, there's going to be clear fluid. These people are going to have hemorrhagic blisters. It becomes a little bit important in a minute. There are various phases to the injury. First of all, pre-phase, the area gets cooled, you get vasoconstriction, you start to get ischemia, you become anesthetic because the nerves become hypoxic, but you don't necessarily get ice formation. Once you hit the second phase, where the freeze-thaw portion, you can get intracellular and extracellular ice crystals. Remember, this is what really causes the issue. You get membrane injury, liver destruction, which then causes clotting abnormalities, and cell death, and further ischemia by small vessel blockage. Once you thaw the tissue, you then enter into the area also of reperfusion injury, just like any shocky tissue. There's massive inflammatory mediator release. You have vascular stasis, constriction, dilation of the vessels, leak through the vessels in the area, coagulation defects, and destruction of the microcirculation, which furthers the injury. This will become important in a second. So what do you do about it? Well, the first thing you do is, if the patient is also hypothermic, which is certainly can be the case, you're going to treat that first. You're going to rehydrate the patient. We already talked about this. You're going to immediately rewarm the patient in 40-degree water. And interestingly enough, they've actually studied this, and 40 degrees does seem to be optimum. The drop-off in improvement, even with a couple of degrees like 38, 39, actually is significant. Conversely, if you're too high, you can actually cause tissue injury. Okay, so, but first of all, you've got to make sure there's no further freezing. So this is if you're outdoor adventurer and your feet get frozen, you don't thaw your feet if you then have to walk back in a condition where you're going to refreeze them. So thawing, the thaw-freeze cycle is worse than just having them frozen once. Blisters, I mean, just like burns, people get blisters. This is basically what people think. White blisters have a lot of prostaglandins and exudate inflammatory mediators in them. These are the clear blisters. These are with superficial injuries. You probably should debride these, get the mediators out of there, and you can treat those with actually aloe. If they're hemorrhagic, however, that meaning there's blood in there. This suggests that the injury is deep, and you probably don't want to debride these because they'll become more desiccated. It's suggested that all these people should be started on ibuprofen. And as we saw, a lot of this is an inflammatory issue. Now, one of the things that's come up recently, and I think it's fairly new, is if there's no Doppler pulse and no flow on triple phase bone nuclear studies, and you're less than 6 hours from injury, you can give TPA and actually have a significant recovery. If it's less than 6 hours, you give them IV TPA, that's all you need to do. If it's more than 6 hours but less than 24 hours, you can try interarterial TPA to the injured area. If you do this, they need to be followed up with heparin. And then the question is, do they need to be transitioned to warfarin? And nobody knows the answer to that. But this is what it looks like. This is obviously somebody's feet, and you can see that there's no flow beyond there. This is amenable to TPA if it's within the first 6 hours and it's the first time it occurs. The problem is that most of what we're going to see probably is something that's been frozen and thawed or frozen for an extended period of time. And you can't do anything about that. Once you're past that 24 hours, TPA is not going to be of value. And if it was frozen, they thawed out, then froze again, TPA is going to be of no value to that. If that's the case, you're going to dress the wounds with aloe vera or Silvadene. If you can do a bone scan or an angiogram, it may indicate the level of amputation. Again, if this is early on in a repeat, you can amputate here. Otherwise, if you don't have this, then you just wait 3 to 6 weeks. That was the old dictum. You never amputate a frostbitten extremity. You never do anything for at least 6 weeks. If you can look at this bone scan and see there's no circulation, you can safely go ahead and amputate at that level. Beyond that, go back to the old dictum, 4 to 6 weeks before you do anything definitive. Just keep the wound dressed, keep it elevated, keep the aloe on it, keep the Silvadene on it, keep it from getting infected. Okay. So, finally, come to the final injury, trench foot. Really first described in World War I with soldiers in the trenches, feet got cold. This is a non-freezing injury. You don't have to have freezing temperatures to get this. What it is basically a combination of low flow cooling and neurogenic injury to the local area. Produces a peripheral neuropathy, mainly with the large myelinated fibers. May or may not produce ischemia, nobody really knows. And it's complicated by that hunting response. Remember what I talked about very early on, where once you reach a certain temperature in the local area, you start to getting open, and the local channels open and close without control, which actually, in the long run, causes increased cooling and increased tissue loss and increased ischemia. So, basically, as we said, this is a neurologic, predominantly neurologic injury, causes vasospasm. You can get prolonged vasoconstriction along with this hunting response, damages the endothelium, causes gaps occur in the endothelium. You start to have tissue leakage, which of course produces edema, which of course decreases flow further. Holes can be plugged with leukocytes and platelets, which then can make the air, increase ischemia to the area. Eventually, the tissue dies. Nitric oxide, once again, rears its head here. It's part of the mediating process, as we said again in the early, when we talked about the channels in the skin. What its real role is, nobody really knows. But we may be giving these people Viagra in the future. Who knows? There are three phases to trench foot, and this is, I think, the thing you're most likely to see down here. There's the pre-hyperemic, hyperemic, post-hyperemic. Pre-hyperemic, there's going to be significant vasoconstriction, tissues blanched, yellowed mottled, edema is minimal at this time because you have decreased flow, you don't have that leakage. Pulses may be absent, the patient is going to be numb and have loss of sensation, particularly proprioception. Hyperemic occurs after rewarming. It becomes hot, erythematous, very painful, in fact, very hypersensitive to everything. It's due in part to uncontrolled vasodilatation, and you've lost your ability to vasoconstrict here, and it may last, this period may last weeks. So what these things look at, I mean, this is the pre-hyperemic phase. Doesn't look that bad, does it? Then you move on. This is after, remember, this is after you've started to reheat. And all of a sudden, you get the feet are red, they're swollen, and it can go on for an extended period of time. This is the late period. Post-hyperemic may last weeks to years. Once you have this, I mean, if you're in the military, this makes you ineligible for deployment, basically ends your career. It may last weeks to years, has constant dull pain. You may also have anesthesia, hyperhidrosis, the decalcification of the bone, typical of neuropathy. And you are, of course, sensitive to any further cold stimulus. Eventually, if you allow this to progress, you get tissue hypoxia, and I think this is self-explanatory. This is from the Falklands War. Argentinian mine layer wore his boots for 47 straight days. This is would be very typical of First World War also, during the Falklands War, and this is what he ended up with. And remember, none of this is a freezing injury. So what do you do for this? Well, first of all, you've got to distinguish whether there's frostbite there as well. Because, I mean, you certainly can have both things going on at the same time. Obviously, I talked about how the second phase goes on for weeks, the third phase goes on for years. Obviously, prevention is the way to go here. And that basically is all of these things. Change your footwear. I mean, it sounds silly here, but you talk about homeless people, you're talking about soldiers out in combat. It's sometimes harder to do. Should change your boots or socks 3 times a day if you're in this situation. There are other things you can apply to it, but there's no magic. Keep your feet dry and keep them from getting cold. Once you see these, elevate the extremity. Don't make it dependent. Seems counterintuitive, but you cool the extremity. Not make it cold, but you cool it off with cool air. You're now assuming that you've returned the patient to a more normal thermic state. You cool the affected area with cool air from a fan until it's no longer painful. If you warm it, you're going to get massive vasodilatation, massive inflammatory release, a reperfusion injury, and you're going to really make things much worse. If you cool it, you decrease the metabolic needs and allow the oxygen to get to the tissue. The UK, the armed forces, try amitriptyline at bedtime. Remember, these things go on for a long time. The jury is out on that, and quinine or quinacrine has been tried. Jury is out on that. So that's basically it. Local injuries, systemic injuries, down to about 32 centigrade. You can passively warm them. Beyond that, you're going to have to do something active to warm them up. just remember the degrees, what you can do with frostbite, which is the most typical freezing injury. Trench foot, you're in for a long haul. Any questions? Great.